Welcome to today's deep dive. So, before a clinician can treat severe chronic pelvic pain with a highly targeted injection, they might actually have to swab the inside of your nose.
Yeah, it sounds completely unconnected, I know. But hunting for a superbug in the nasal passages is actually the final step in this massive microscopic dragnet.
Right, and that is exactly our mission today. We are looking at the meticulous clinical screening framework that is absolutely required before localized autonomic vestibular trigger injections. We're talking about checking for active, hidden infections before they even think about picking up a needle.
Exactly. And patient safety is paramount here. Introducing a needle into an infected area, well, it can have some really serious consequences.
Oh, absolutely. And for you listening, we're basically stepping into the shoes of a medical detective today. We've got a stack of medical guidelines, BASH-RCOT, plus clinical trial protocols to unpack how doctors secure this perimeter.
And, the necessity of that perimeter check becomes super obvious when you look at the mechanics of the procedure itself. We're dealing with provoked vestibulodynia.
Right, where the clinical presentation is severe allodynia, right? Like chronic, unexplained pain right at the entrance of the vagina.
Yeah, exactly. The peripheral nerve fibers in the vestibule are so hypersensitized that just a non-noxious stimulus, like light pressure or even clothing it, triggers this agonizing pain response.
Wow. And to treat it, they're trying to chemically modulate that response. But breaking the mucosal barrier carries some pretty profound biological risks.
It does. But before they even get to the risks, the diagnostic phase is fascinating just because of how localized the pain is.
I know, right? The cotton swab test, I was amazed by this. They just use a simple cotton swab, applying gentle pressure around the vestibule to map out the pain like a clock face.
Right, testing the 2, 4, 6, 8, and 10 o'clock positions.
Yeah.
They're creating a really precise neurological map of exactly where those nerve endings are firing inappropriately.
It's basically like mapping a minefield, you know?
Gotcha.
Just trying to find exactly where the triggers are.
That's a great analogy. And that mapping dictates the intervention. Once those specific trigger points are identified, assuming, conservative management has failed, they move to submucosal injections.
Right, so using local anesthetics or maybe botulinum toxin Botox to paralyze the muscle and block the pain signals?
Yeah, or even steroids and hyaluronic acid. They're delivering these directly into the submucosa to provide relief.
But wait, here is my pushback on this. If you are sitting there with debilitating, burning pain, and we've already mapped exactly where the misfiring nerves are, why make the patient jump through all these infection screening hoops?
It's a fair question.
I mean, if you have a syringe full of Botox ready to go, just give the injection and give them relief, right?
Well, the medical guidelines are incredibly strict on this. An active infection over the site of a trigger point, or even a systemic infection, is an absolute contraindication.
Meaning you just cancel the procedure outright.
Outright. You have to. The reason lies in the physical action of the needle. I mean, the squamous epithelium of the vestibule is this highly effective fortress wall. It's holding back a massive microbiome.
So when the needle goes in,
The moment it passes through that tissue, it acts as a mechanical Trojan horse. It can drag surface microorganisms directly down into the sterile submucosal planes or the deep muscle tissue.
oh, wow. So you're inadvertently causing needle track seeding. You're taking a superficial colonization and manually implanting it into deep tissue.
Exactly. And once it's down there, it has free rein to replicate. That deep implantation triggers an immediate and really aggressive innate immune response.
This is the classic inflammatory cascade, right? The rubor, tumor, calor, and dolor. So redness, swelling, heat, and pain.
Spot on. The immune system detects this foreign pathogen in the sterile tissue, and mast cells degranulate. They just dump histamine all into the surrounding area.
And that histamine dump causes the local blood vessels to rapidly dilate, right? So they can flood the area with white blood cells.
Yeah, and that extreme vasodilation is what drives the calor and rubor, that sudden intense heat and redness at the injection site.
Plus, the capillary permeability increases, which lets fluid leak in and causes the swelling of the tumor. And since we're already dealing with an area with severe allodynia.
Right, exactly. That sudden swelling puts mechanical pressure on those already hypersensitized nerve endings. It amplifies the dolor, the pain, to just an unimaginable degree.
That sounds horrific.
Yeah.
And if the localized immune response fails to contain it, what happens?
Well, worst case, the neutrophils start walling off the infection, creating a deep abscess.
Yeah.
Or the pathogen gets into the bloodstream, triggering bacterial sepsis.
Wow. So the stakes are literally catastrophic. It's not just about treating the pain, it's about not making things drastically worse.
Exactly. Which brings us to the question, how do doctors know if a hidden infection is lurking? The BCH and RCIJ guidelines mandate a really rigorous pre-flight checklist.
Right, the first line of defense. The clinical history and visual inspection. I sort of picture this as a bouncer at a club doing a pat down, checking IDs. It's the basic perimeter check before anyone gets inside.
That's a perfect way to look at it. Before any localized injection, the clinician has to evaluate the patient for systemic signs of infection.
So they're looking for what, a fever over 38 degrees Celsius or 100.4 Fahrenheit?
Yeah, or they check the blood work for leukocytosis, an elevated white blood cell count. Even if there are no local symptoms, a high white count means the bone marrow is aggressively pumping out leukocytes.
Meaning there is an active inflammatory process happening somewhere in the body. So, assuming the systemic vital signs are clear, they move to the visual check, right? The vulvoscopy.
Right. Using high magnification, they're visually inspecting the target tissue. They're looking for atypical skin lesions, abnormal discharge, or localized redness and tenderness outside the map trigger points.
But what if the infection doesn't have obvious symptoms? I mean, what if our bouncer can't see the threat?
And that is the huge limitation of the visual check. It only catches symptomatic presentations. Because vulvodynia is a diagnosis of exclusion, clinicians have to aggressively test for hidden infections using specific lab work.
Right, the microbiological dragnet. This part is wild. So the guidelines require high vaginal swabs to be sent off for extensive microscopy and culture.
Yes, they run a wet mount, they check the vaginal pH, do a fungal culture, and a gram stain. And they are specifically looking for morphological clues, especially with fungal pathogens like Candida.
Right, the yeast infection. They're looking for blastospores and pseudohyphae.
Exactly. And the distinction there is entirely structural. Candida can exist completely peacefully on the mucosa as single budding yeast cells. Those are the blastospores.
But when it becomes pathogenic, it undergoes this crazy morphological shift, right? It forms the pseudohyphae.
Yeah, these long branching filaments.
I was reading about this. They act like microscopic root systems. They physically drive down into the epithelial cells to invade the tissue.
It's exactly like roots. And when the lab sees those pseudohyphae under the microscope, especially if there's a swarm of neutrophils around them, it confirms the yeast isn't just passively sitting there.
It's actively invading.
Yeah.
And the host's immune system is fighting a war against it.
Right, so injecting a local anesthetic or Botox right into that microbiological war zone would suppress the localized immune response and physically push those invasive filaments even deeper.
Okay, so that's the fungal side. But the bacterial side of the dragnet is just as intense. They also do STI screening, right?
Yeah, the framework requires checking for sexually transmitted infections that cause inflammation. So they mandate nucleic acid amplification tests, or NAET, for chlamydia, gonorrhea, and trichomonas vaginalis.
And NAET is the gold standard here because of its sensitivity, right? Because unlike traditional cultures where you have to grow the bacteria in a petri dish, NAET operates on a molecular level.
Exactly. It uses PCR polymerase chain reaction to target highly specific sequences of the pathogen's DNA or RNA.
Oh, this is the thermal cycling thing, where it separates the DNA strands, binds specific primers, and then an enzyme just copies it exponential.
Spot on. So even if there are just a few copies of chlamydia DNA present levels that are way too low to show up on a standard culture, the NAT amplifies it until it crosses the detection threshold.
That is incredible. But let me ask you this. If all these swabs come back negative, is the patient 100% clear of infection? Like, mathematically, how do you justify sticking the needle in?
It's a great point because a negative swab doesn't entirely rule out deeper issues like pelvic inflammatory disease or PID.
So you're still taking a calculated risk.
You are, but the guidelines lean on the negative predictive value of the microscopy to mitigate that risk. They specify that the absence of endocervical or vaginal pus cells on a gram-stain smear is highly reassuring.
So it's not just about the absence of the bacteria itself, it's the absence of the immune system's footprint.
Exactly. It carries a 95% negative predictive value. If there were a hidden upper tract infection, those neutrophils and pus cells would be spilling down. Their absence basically gives the green light for the general area.
Okay, so the general area is clear. But what if we zoom back in on our clock face? Let's say the blood work is good, the NAT is negative, no pseudohyphae. But right at the 6 o'clock position, exactly where the needle needs to go, there is a visible, localized lesion.
Then the protocol changes entirely. The RCIJ guidelines flip into this highly stringent site-specific protocol. Any lesion at the planned injection site must be aggressively swabbed.
And this is where the MRSA screen becomes mandatory. Methicillin-resistant Staphylococcus aureus.
Right. MRSA is a strain of staph that has acquired a specific gene, the MECA gene, that alters its penicillin binding proteins. That single mutation renders entire classes of antibiotics totally useless.
So introducing MRSA into the deep tissue via needle tract seeding would be an absolute nightmare.
It would be catastrophic. Because it resists standard antibiotics, the resulting abscess or sepsis is incredibly difficult to manage. So if a patient is prepped and there's a lesion, the clinician needs to know their MRSA status immediately.
And here's where we loop back to that seemingly unconnected diagnostic tool from the beginning. They swab the inside of your nose.
Yes, they send a pre-moistened nasal swab for rapid MRSA screening.
It's just wild how indirect that connection is. Checking the nasal mucosa to secure a pelvic procedure, but it's because of autoinoculation, right?
Exactly. Staph aureus preferentially colonizes the anterior, nares the nostrils. The warm, moist environment there is its primary reservoir. And a lot of people are just asymptomatic carriers.
So the bacteria is just hanging out in the nose without causing an infection. But if the patient rubs their nose, they get MRSA on their hands.
And from there, they can inadvertently auto-inoculate any other region of their own body, including the pelvic region, just during basic hygiene.
Wow. So by using a rapid test on the nasal swab, the lab can identify that colonization almost instantly. And if the nose is positive, the statistical probability that the pelvic lesion is also MRSA skyrockets.
Right. And in that case, the clinician cancels the injection, pivots to targeted decolonization or very specific non-beta-lactam antibiotics, and avoids seeding a superbug.
When you step back and look at the sheer thoroughness of this entire process, it's really amazing. I mean, from mapping the pain on a clock face to checking for microscopic pseudohyphae to swabbing the nose for MRSA.
It's a huge operation.
It really is. It perfectly illustrates how modern medicine balances the urgency of pain relief with this ironclad safety net. You have to rule out hidden infections first to prevent catastrophic complications.
Absolutely. But, there's this really fascinating new frontier mentioned in the sources that completely challenges how we view all of it.
Oh, right. This is the research about the fibroblasts.
Yeah.
Blew my mind. So they isolated the structural cells, the fibroblasts, directly from the vestibules of patients suffering from this provoked pain.
Yeah. Traditionally, we think of fibroblasts as just the passive scaffolding of the tissue, right? They produce collagen, they maintain the structure.
But when researchers analyzed the fibroblasts, taken specifically from these painful regions, they found that the cells themselves were highly sensitized.
Yes. Even without the presence of an invading pathogen, no candida, no MRSA, these specific fibroblasts were producing copious amounts of pro-inflammatory mediators, specifically interleukin-6 and prostaglandin E2.
And IL-6 and PGE2 are massive players in the inflammatory cascade. PGE2 directly sensitizes the peripheral nerve endings, which lowers their threshold for firing.
Which is the exact definition of the allodynia we see in these patients. It suggests that, at least for some patients, this chronic pain is actually driven by a localized, site-specific endogenous inflammatory loop.
That completely flips the script. So the threat isn't necessarily a bug hitching a ride on the needle, but the tissue's own cellular architecture continuously sounding the alarm.
Exactly. The vestibule's own cells are stuck in a hyperactive state, pumping out cytokines to keep the nerves in agony.
Which means the future of diagnosing and treating this could look totally different. Instead of hunting for pseudohyphae and nasal MRSA, future pre-injection screenings might just swab the vestibule to look for these specific inflammation markers.
Right. If we can map the exact cytokine profile those overactive fibroblasts are producing, clinicians could theoretically inject targeted monoclonal antibodies or localized cytokine inhibitors to just shut down the factory causing the pain.
Wow. It's a thought that completely reframes how we might treat chronic pain in the future. But until those targeted therapies arrive, the current protocol holds the line.
Absolutely. Clinicians will keep checking every vital sign, amplifying every strand of DNA, and searching every mucosal reservoir before they let that needle cross the epithelial barrier.
And honestly, knowing what's at stake, I wouldn't have it any other way. That wraps up our deep dive for today. Thanks for stepping into the medical detective shoes with us, and we'll catch you on the next one.